Let's slowly start. Good day, good morning, good evening to wherever you are in the world. My name is Peter Roeleveld. I'm a pediatric intensivist from Leiden in the Netherlands and a member of the EuroELSO steering committee. And I'm happy to welcome you to another EuroELSO webinar. And today is actually the first combined pediatric and EuroELSO, an adult EuroELSO webinar. So I'm happy to welcome Jordi in a moment, who is joining me as a host for this webinar. But first, before we start off, a few housekeeping details. We'll have a talk first by our speaker, who will be introduced in a moment. And then afterwards, questions will be relayed by Jordi and me towards Graeme. You can put your questions during the talk into the question box from this GoToWebinar panel. And again, Jordi and I will relay them then. This entire webinar will be recorded and will be available from the EuroELSO website in a few days. And before we start off, I want to remind you of the EuroELSO conference that is happening in May in London. So if you've got time, please come and join us there. Okay, now let's start by introducing Jordi. Jordi Riera is a adult intensivist from Vall-d'Hebron Hospital in Barcelona, in Spain. He's a director of the ECMO program there, and he's a colleague of mine from the steering committee of EuroELSO. So welcome, Jordi. Jordi will represent the adult side of things. I will do the pediatric things, but our speaker can actually do both. So welcome, Jordi. The floor is yours.
Thank you, Pete. Thank you, Pete, for this kind introduction. It is my pleasure to moderate with you, share the moderation with you. In this EuroELSO webinar, again, our society tries to disseminate ECMO knowledge all over the world, wherever you are, crossing boundaries, frontiers, and thanks to the technical help of Interplan. Welcome, everybody. Welcome. Thank you for being there with us and sharing with us this so interesting webinar. Hope you enjoy it. And for today, we have a very important topic indeed, which is infectious complications in ECMO patients. So frequent, they are somehow subreptitious and with a very big impact on our patients. We see it every day. And also, we have the possibility of using ECMO in those very severely ill patients with very severe septic shock. So very interesting topic. And trust me, there's no better expert than Professor MacLaren to put a light on this complex issue. He is pediatric intensivist in Melbourne, Australia, director of the adult intensive care in Singapore, member of the ELSO steering committee, and editor of the upcoming edition of the ELSO Red Book. This is a very brief summary, but he's an expert with, he's a referent for anyone who is interested in this topic. So let's start. If you agree, enjoy and participate. Put your questions in the box. We'll try to address all of them. And please, Professor, the virtual podium is yours.
Oh, well, thank you very much, Pete and Jordi. Can I just confirm you can see my screen?
Yes, we can.
Yes.
Lovely. Okay, thank you so much. So this is a topic which is very dear to my heart, the interplay between ECMO and infection, how one can lead to the other. I have no disclosures on this topic. So this is a two-part talk. The first part will focus on the nosocomial complications of ECMO, and I think this is relevant irrespective of the patient that you're looking after, whether it's a premature neonate or a geriatric patient. The infectious complications of ECMO are serious. They have very significant implications, and I don't think that they have been examined closely enough. So I think this is an excellent opportunity for us to reflect on what we know and what we don't know. The second part of this talk will be on the use of ECMO for infection. Now, obviously, we've been doing ECMO for infection for decades. So why should we talk about it now? Well, in the middle of the pandemic is one reason, and another reason is to focus specifically on the use of ECMO for mechanical circulatory support. So this is something that's been in the pediatric world now for nearly 3 decades, but it is only just starting to gain attention in the adult world for reasons that we will explore in depth. So after this 2-part talk, I will conclude with what I consider to be 10 kind of practical clinical tips that I hope will be of use to people at the bedside. Obviously, the audience to a webinar like this may range in experience. Maybe there's some people who have only just started doing ECMO. Maybe there are people who are better qualified to talk on this subject than I am. So I hope that we can all learn something together. As Pete mentioned, this is going to be a webinar that addresses the infectious complications and the use of ECMO for infection across all ages. And I think, yes, there are differences and there are important considerations in different age groups. But again, I think it's important that when we look at the use of ECMO in these patients, that we keep an open mind. If, for example, you're an adult clinician and you say, oh, if the patient's less than 15, I'm not interested, I think you're missing out on an opportunity to learn something. The currents of thought in the pediatric world, perhaps in some respects, they may be more advanced than in the adult world, and of course, vice versa. And I think the flow of information needs to go both ways, and that will only happen if we listen to each other. So I hope that this will be relevant for everybody, even though it may not focus at times on your specific patient population. So to begin with, I'd like to focus on the nosocomial complications of ECMO. I'm going to reference a paper that I published a couple of years ago, which it was actually meant to start life as a systematic review and meta-analysis. But as one reviewer cogently pointed out, a systematic review really needs a specific question. And this was really a scoping review rather than a systematic review. So it was published as a comprehensive narrative review in Pediatric Critical Care Medicine a couple of years ago. Nonetheless, the methodology followed that of a systematic review. So we looked at about nearly 1,000 articles and managed to whittle them down to 59. Again, the aim here was to focus on nosocomial complications of ECMO, irrespective of age. So let's take a moment to reflect on the epidemiology. If you look at those studies which were published in the beginning, so back in the 1990s, for example, you will see all of the studies talk only about the risk of infection on ECMO. So they will say, oh, so during a given ECMO run, let's say it's a 3-week ECMO run, the risk of that patient developing an infection was, whatever, pick a figure, 20%, 50%. But of course, this is a very, very blunt tool, and it doesn't allow for repeated infection. So risk is a very crude marker, and I think, thankfully, more recent studies have moved beyond it. So instead of talking about risk, we should talk about incidence. So what is incidence is defined in this context as the number of infections per 1,000 ECMO days. And as you can see from this table, there is a huge variation in the incidence of reported nosocomial infections during ECMO. And this is only a handful of studies, I should add. And this is because I think there are differences in the incidence of nosocomial infection across different age groups. In general, the older you are, the more important infection becomes. Just as the smaller you are, the more important thrombotic complications become. So if you're a clinician who's used to managing small babies on ECMO, that's your day-to-day practice, you will know that the major management concern for most of those children is how to prevent and manage thrombosis and bleeding. Whereas if you're looking after adults all your time, who may be on 4 or 5 liters a minute of ECMO flow, thrombosis and bleeding, yes, they're important, but they're not at the top of the management list in every patient every day. But over time, particularly on veno-arterial ECMO, nosocomial infections become progressively more important. And I think that's the reason that we cannot offer conventional VA ECMO for weeks or months on end. VA ECMO is a short-term support therapy. It's not medium-term. It's not long-term. It's not like a ventricular assist device. And I think the dominant reason for that is the importance of infectious complications. Another reason, of course, because behind the variability in the numbers you see in the far right column is because the definition of infection is not being used consistently. Some of these studies don't even define what an infection is. Some of them kind of lazily assume that any positive culture equals infection, which of course doesn't distinguish between colonization and infection. There are very few studies, maybe a quarter of the studies that are out there have used appropriate definitions, and I think the most appropriate is that of the CDC. In terms of microbiology and site, this varies with the age of the patient. In neonates, for example, the most common organisms are coagulase negative staphylococcus and candida. In older patients, it's basically the same that you would see in your ICU in non-ECMO patients. So nosocomial infections with Staph aureus, with Enterobacterales, with Pseudomonas, these are the infections we see. Again, in young infants, we generally see bloodstream infections. In adults, ventilator-associated pneumonia is the most common. Now, the largest of all of these studies in this segment of the talk is the study by Matt Pizarro from Yale, which was published, I think, back in 2011 or maybe 2013 in the Pediatric Crit Care Med, just over 20,000 patients from the EuroELSO registry. And you can clearly see that with an increase in age, there was an increase in the incidence of infection. So this is the kind of background to this topic about nosocomial infection. So what are the risk factors for infection? Well, clearly the cannulation strategy has an enormous impact. If you think about this, the longest ECMO run with success to date is 604 days. So there was a 7-year-old girl in Johns Hopkins in Baltimore who was treated with a very, very difficult run, obviously, but it took 604 days, but she managed to make it home. Now, can you imagine doing veno-arterial ECMO for 604 days? I think not. You're never going to manage that. So the principle that I think is that venous ECMO, you select the correct patient, you provide good nursing and medical care, and you sit on your hands and you wait. The patient will either develop a life-limiting complication or they will survive. That's it. On veno-arterial ECMO, that is not the principle that you can follow, because every day the cumulative risk of complications becomes eventually overwhelming. So veno-arterial ECMO is more like a time bomb. You need to get them off ECMO as fast as you can. And I think a lot of that is determined by the infectious complications. So we know that VA is worse than VV. Amongst the VA complications, we know that central ECMO is associated with much higher incidence of infection than peripheral. We know that open surgical cannulation strategies are associated with greater infectious risk than percutaneous. Another important risk factor are mechanical complications during ECMO. So that means that, for example, if you have pump failure or your oxygenator clots off and you need to do a circuit change, the breaching of the sterile circuit, the exposure of the patient's blood and the ECMO circuit to the atmosphere of the ICU, not surprisingly, is associated with a substantial increase in the risk of nosocomial infection. But perhaps the most important risk factor is duration. And this is a complex relationship. And it's been demonstrated in pretty much every study on this topic, irrespective of age. So the longer you are on ECMO, the more likely it is that you will develop a nosocomial infection. But at the same time, if you develop a nosocomial infection, that will prolong your ECMO run, which means that infection during ECMO is both a risk factor and a consequence for a long ECMO run. I don't want to focus too much on individual studies, but this one is a very nice illustration. This is from La Pitié-Salpêtrière Hospital in Paris. It's over 10 years old now, but it shows very elegantly what happens. These are all adult patients supported on veno-arterial ECMO. And you can see this Kaplan-Meier curve on in the top left there, that by the time the patients have been on ECMO for about 3 weeks, 85% of them have had at least one nosocomial infection. And by the time they're on for over a month, they've all had it. Now here in Asia, we have, it's obviously, there are cultural differences between countries and regions. And we've been exposed to the scenario in the past where certain members of the medical team, for example, the surgeons, refused to withdraw care, the family refused to withdraw care, and the intensive care team are left stranded in the middle. So I have seen these patients kept on veno-arterial ECMO for as long as possible. And in the end, they all die of fulminant septic shock. And you can use antibiotics and you can use inotropes and you have higher ECMO flow, but it doesn't work. So in the end, veno-arterial ECMO is a death sentence. And I think it's because of these infections. So we need to get these patients off ECMO as fast as we can. And this is illustrated nicely in this. This is looking at children. These data were culled from 8 pediatric hospitals in Japan, plus the Royal Children's Hospital in Melbourne. And you can clearly see these were all children with post-cardiotomy ECMO. You can see that there is a decrease over time, to the point that by the time the child has been on ECMO for 10 days or more, the chance of that child leaving hospital is less than 20%. And by the time that they've been on for more than 2 weeks, that is approaching zero. Now, obviously, this is not just because of infectious complications, but again, it illustrates the principle about the short-term nature of veno-arterial ECMO. If I don't have curves to match that for veno-venous, but of course the curves for VV would not look anything like this. Moving on to outcomes, again, if you're an adult clinician and you have looked at this literature, you might be of the view that nosocomial infections do not have a mortality risk associated with them. And I think that's because a lot of these studies are underpowered. There are a lot of single center retrospective studies out there which do not demonstrate an association between increased mortality and nosocomial infection. That is not the case so much in pediatrics. There's quite a clear signal there. But if you look at the largest studies of all, again, they're all studies of the ELSO registry. For example, this one by Vogel et al., nearly 40,000 patients, irrespective of the patient's age. If the patient developed a nosocomial infection during ECMO, they had an increased chance of death. So this is an important topic. Unfortunately, I don't think it's received enough attention. We've discussed briefly the problems with definitions, which means it's very hard to compare one study to the next. There have been very few studies on how to prevent infection. There have been no trials at all comparing different treatment strategies using antibiotic regimens, whether it be dose-related or duration. And there have been relatively sparse studies on the pharmacokinetics and pharmacodynamics of antibiotics during ECMO. There is some in vitro work, yes, but we don't have a good handle on the PK/PD of every antibiotic across all age groups in ECMO. And there have been no randomized studies of this issue at all. 2 years ago, Daryl Abrams and colleagues published this review in intensive care medicine, which was really trying to assert what we didn't know. This was a proposed research agenda, which I think raises a number of important questions related to prevention, diagnosis, and treatment, and highlights those of us who wish to study this in more detail where we might start. I've come up with my own list here, but the 4 key principles that I think is how to move the field forward. First of all, we need to start using standardized definitions, and I think the most appropriate are those of the CDC. Second, we need to continue the work that many groups around the world are doing on studying the PK/PD of antibiotics during ECMO. Again, it has to be done across different age groups. There are huge differences in pharmacokinetics compared, say, neonates to geriatric patients or very small patients to very obese patients. So all of this needs to be studied in detail. And Kieran Shakar in Brisbane is one authority on this who's doing some very nice work, both historically and again in recent times, but more work needs to be done by other groups. We need preferably randomized controlled trials comparing treatment duration, whether these are superiority studies or non-inferiority studies. We don't have anything at the moment, and it's, I think, about time we got them. And then lastly, we need trials of prevention. Again, in Brisbane, John Fraser's group is doing some nice work looking at, for example, coating ECMO cannulas with various antibacterial properties to try and prevent colonization of the ECMO cannulas, which obviously can be difficult or impossible to change during an ECMO run. And also just this very simple idea, just as we do with our oncology patients, of tunneling the ECMO cannula. If you have time, surgically tunneling it to try and reduce the risk of cannula site infection. So again, there is very little prospective research being done on this, and it's about time we started. So let's move away from the infectious complications of ECMO and toward the use of ECMO for infection. Now, of course, there's a number of different ways of looking at this. We can look at it about different organisms. So there have been hosts of studies looking at, what are the outcomes after, for example, neonates with group B streptococcus? What about adults with community-acquired pneumonia? What about children with Staph aureus infection? There's lots of these studies. The issue, particularly with respiratory failure, though, is that most of these infections just trigger an end-stage response, which is ARDS. So by the time the patient winds up on ECMO, the inciting event is no longer relevant. Because it all winds up being ARDS in the end. Now, there are a number of important exceptions to this, particularly in very young children. Neonatal adenovirus, for example, is associated with more than 85% mortality. Disseminated herpes simplex virus with about 75% mortality, and infant bordetella pertussis in those poor children who haven't been vaccinated yet, usually around 2 to 3 months of age, who develop these horrendous pertussis pneumonias, are associated with about 70 to 75% mortality. And then, of course, more recently, we've seen adult COVID, which I'll get to in a minute. We also have different populations, and in particular, I think a population of interest to many of us would be the oncology patients. These are difficult patients to get through an ECMO run. 10, 15 years ago, I think it's fair to say that most people would regard an allogeneic bone marrow recipient as an absolute contraindication to ECMO because they had 100% mortality. That is starting to change now, and I think we've seen publications in the last 2 years showing that in very, very selected patients under specific circumstances, these patients may have outcomes as good as 25% survival to hospital discharge. So I don't want to get into this in too much detail. It's a controversial subject and not one to be brushed aside. Nonetheless, I think it's fair to say that an allogeneic bone marrow transplant is no longer an absolute contraindication to ECMO. Similarly, febrile neutropenic sepsis is a difficult group of patients to get through, and it's not just the sepsis and the neutropenia and the immunoparesis. It's a fact of all the other things that come with it. Their integument is fragile. You touch their gums and they bleed. They're often profoundly thrombocytopenic, which makes ECMO very difficult. So I don't want to focus too much on ECMO for respiratory failure, for infection-induced respiratory failure. We know that these patients, on the whole, the majority of them do quite well. What I want to do instead is focus on the use of ECMO, veno-arterial ECMO, for mechanical circulatory support. But just before I get there, it would be, I think, tone deaf of me not to talk about COVID very briefly. Obviously, COVID and ECMO is a hot topic and it deserves its own webinar, and I don't want to derail this presentation, but I can't ignore it. So these were 2 viewpoints. One was published, one was written in February 2020 when COVID emerged and was causing problems in China, but very little elsewhere. It was before it had hit Italy and Western Europe. But then the second one, we felt that the message had changed and needed to be, there was a different message to be heard. We had much more observational data then, we had far more experience. So this one was written in mid-February 2021. Again, I'm not going to dwell on the details of this. They're freely available online for those of you who wish to read it, but it was our interpretation of the role of ECMO for COVID. This study by EuroELSO was published in October 2020. And the message from this was pretty clear, which was that the 90-day mortality for COVID patients receiving ECMO was 37%, which was comparable to the patients in the treatment arm of the EOLIA study and what we would really expect. So the message was, go forth and provide ECMO for your COVID patients, just like you would any other viral pneumonia. But it became clear over time that this message had changed. So almost a year to the day later, there was a second study published with nearly 5 times as many patients, showing that the median duration of support had gone up by nearly a week, which has huge implications from a resource point of view. And also that the absolute increased risk of death had gone up by 15% to 52%, even in experienced centers that had been offering ECMO for COVID the entire time. So this was no longer just your average viral pneumonia. This was now the majority of patients being put on ECMO after May 2020 were dying, at least in this publication. So this was the first time I think that we've demonstrated clearly that outcomes can rapidly change over time with the use of ECMO for infection. However, again, I don't want to dwell on this for too long, so I want to move forward and talk about this, which is the use of ECMO as mechanical circulatory support for septic shock. Now, pediatric clinicians are familiar with this concept, adult clinicians perhaps less so, depending on whether they have looked after children in the past. If you ask an adult clinician what is the characteristic hemodynamic manifestation of septic shock, they will say, well, obviously it's distributive shock. So the left ventricle dilates, the patient becomes tachycardic, they're flushed, they're febrile, they are vasodilated, they're often fluid responsive, particularly in the early stages, and their cardiac output goes up. And therefore, why would I want to give ECMO to that patient? Which is a very good question. Why would you? Whereas that's not the universal response. If you look at newborn babies who become septic, usually through group B streptococcus, of course, the characteristic manifestation of septic shock is right heart failure. So they get something called persistent pulmonary hypertension of the newborn. So they have very high pulmonary vascular resistance, dilated, poorly functioning right ventricles. And therefore, ECMO is an excellent treatment for that. First of all, ECMO will take over the function of the right ventricle, and it will lower intrathoracic pressure, increase oxygenation in the pulmonary vasculature, and thereby reduce pulmonary vascular resistance. And most importantly, neonatal sepsis is a condition which is usually very rapidly treatable. So the natural history of neonatal sepsis is it goes away after 3 or 4 days. So that's perfect for ECMO, whereas that is, of course, not the case with adult ARDS, for example. In slightly older children, for example, toddlers, they got what used to be called cold shock and what adult clinicians might call a septic cardiomyopathy. So if you echo them, you will see this left ventricle is barely moving, and they feel cold and shut down, and the lactates are high. So again, ECMO is a natural therapy for this, intuitive therapy for this, because you're replacing the function of the left ventricle, just as you would, for example, if the child had myocarditis. In those older patients, the adolescents and the adults, then automatically ECMO doesn't seem to be such an easy fit for distributive shock. Now, unfortunately, while I can happily sit here and classify it like this, it doesn't work like that in practice. We do get adult patients with septic cardiomyopathy. We do get adults with predominantly right heart failure, and we do get young children with other patterns of shock. So you can't just tell from the end of the bed what the pattern of shock is. It requires detailed clinical examination and echocardiographic examination by an experienced intensivist. And the other important point of note is that these things can change over time. And a lot of the recent work in adults has demonstrated these patients were often coming in, fluid resuscitated, were in distributive shock, but then over the next 24 to 48 hours, they evolved into a different pattern of shock and they developed a septic cardiomyopathy. Again, focusing on children for a second, this, I think, demonstrates how important the pathophysiology of the disease is in young children. This is not the case in adults at all. Multi-organ failure from sepsis in children is very different to that of adults. If you think about adults who die of multi-organ failure in the ICU, it's usually they come in after an inciting event, they spend weeks in ICU, they get intractable multi-organ failure, and then they either have care withdrawn because they're not getting better, or they develop a new life-limiting complication. That is not the case with most children. If you look at these two publications, for example, one in PCCM and one in ICM, one is an Australian New Zealand study, the other is a UK study, and both of them show comparable events, which is of those children who eventually died from septic shock, half of the deaths occurred in the first 24 to 48 hours. So of course, that is not the pattern we see in adult septic shock at all. So if you think about that, there's a couple of important implications. First of all, if you're doing a study of this, let's say you have a new treatment, that treatment is going to have to work blindingly fast, probably faster than antibiotics, in order to try and change the natural history of that. The second thing, of course, is that ECMO may provide a way of extending that period to prevent death in the first 24 to 48 hours and allow your treatment to work. So this is another reason, I think, why the use of ECMO for septic shock has cottoned on much faster in children than it has in adults. A couple of years ago, we put together a systematic review and meta-analysis of the extant studies on children with septic shock being treated on VA ECMO. And this is just to give you a kind of rough ballpark. So there were 9 studies, 208 children, and about 2/3 of them survived to hospital discharge. So we'll try and keep that figure in mind when we do the same with the adults later. Of those, the studies in that SRMA, I think this is probably the most important. So the Australia New Zealand Intensive Care Society and the ANSPIC registry is, I think, amongst the most robust ICU databases on the planet. It's federally funded, so the Australian New Zealand governments pay for it, the whole thing. They have professional data collectors collecting all the information who don't have other responsibilities. It is legally mandatory for your ICU to submit these data. You can't you can't kind of wiggle out of it. So as a consequence, the data are very robust. So these investigators looked at nearly 5,000 children with sepsis or septic shock and looked at the group who were supported on VA ECMO, and there were 80 of them. And the statistician Lanstrani constructed a model with 12 variables, which predicted the chance of death with an area under the receiver operating characteristic curve of 0.88, so quite discriminating. And this is the only study, to my knowledge, that's been able to demonstrate this, which is at what point should you offer ECMO? Now, the cutoff in actuality was 47.1%, but let's call it 50% for convenience. So the curve on the right, what this means is that if the predicted risk of death was less than 50% and you put the child on ECMO anyway, you actually made their outcomes worse. Whereas if the risk of death was more than 50% and you put the child on ECMO, then they did better. So there were a couple of other variables associated with better outcome, not surprisingly at all. The lack of cardiac arrest before ECMO and low lactates before ECMO were associated with better outcomes. And yes, you may say, well, that's because the children weren't so sick, but it also could mean that you got in there early. And there have been plenty of other studies, particularly in the cardiac surgical population, about the importance of getting in early in patients who require ECMO. And the other point in this study was that central cannulation was associated with an improvement in survival. One feature I haven't shown here, which was shown in another study by Felix Oberender, who looked at the data from Australia, New Zealand, and North America, demonstrated that high flow ECMO was also associated with better outcomes. It was associated with better outcomes than low flow ECMO or no ECMO at all, with high flow being defined as 150 mils per kilogram per minute, which of those of you who are not accustomed to looking after small children, 150 mils per kilogram per minute, that is a very high ECMO flow. So this has crept into a number of societal guidelines that just, it hasn't even occurred to adult guidelines to put this kind of material in here. I understand why, but this is what's happening in pediatrics. So this is the American College of Critical Care Medicine statement from 5 years ago, and you can see the algorithm on the right, and clearly at the end they say, if nothing else is working, then you should consider ECMO for refractory shock. 2 years ago, the first ever pediatric surviving sepsis campaign was published, again, jointly in ICM and PCCM, and there is a recommendation to use veno-arterial ECMO as rescue therapy if nothing else works. Now, those of you who have scrutinized these guidelines in detail or who have been involved in the writing of them will know that there is this tremendous focus with the SSC on evidence-based medicine. So expert opinion doesn't really cut it. So yes, it was a weak recommendation and very low quality of evidence, which I think is fair, that's what it is. But nonetheless, the recommendation was made to consider it. And of course, those of you who are familiar with the adult SSC guidelines will know that ECMO doesn't darken the pages of those guidelines. So that's considerations in children. Let's move forward to the adult group. So we've seen that most adults with septic shock develop distributive shock. So how have we done applying ECMO to distributive shock? The answer is not very well at all. These studies, these are a handful of studies. Interestingly enough, they all come from Asia. So we have Taiwanese and Korean studies looking at the application of veno-arterial ECMO in advanced distributive shock. Very, very sick group of patients. Nearly half of them wound up having a cardiac arrest before ECMO was applied. Of course, you can only imagine that if you wait until the point that your patient with refractory progressive septic shock has a cardiac arrest, then ECMO is not going to salvage that many. And sure enough, less than a quarter of all the patients in these studies survived. If we look at the single outlier before 2020, we have this study by Nicolas Brachot from La Pitié-Salpêtrière Hospital in Paris, which, yes, very small numbers, only 14 patients, but demonstrated that the majority survived. And this, of course, was due to very careful patient selection. So these were the patients I was referring to earlier who had presented with adult septic shock, initially characterized as distributive shock, but then had gone on to develop progressive ventricular failure, a septic cardiomyopathy. And once that had been identified, they were put on peripheral veno-arterial ECMO, and the majority of them did well. And this correlates to comparable literature in pediatrics, where irrespective of whether it was cardiogenic or distributive shock, the use of central ECMO was associated with comparable outcomes, where about 3/4 of the patients survived. So the use of ECMO for distributive shock in adults in an indiscriminatory fashion is not something that most people would recommend. And then, of course, 2 years ago in August 2020, I think we saw the most important study on this topic, which again was by Nicolas Brachot and colleagues, who looked at data from, I think, 4 French ICUs and compared them to 3 French databases. Sorry, there were 3 French ICUs and Columbia Medical Center in New York. So they had 82 ECMO patients, 130 controls. All of them had severe cardiogenic shock from documented infection. And despite the fact that the ECMO patients had more severe shock, much higher inotrope doses and worse organ dysfunction, the unadjusted 98-day survival in the ECMO patients was significantly higher than in the control patients, 60% versus 25%. Once they had adjusted statistically for severity of illness and other factors, then again, the ECMO patients still had a much better outcome of 51% versus 14%. So I think, again, this just emphasizes that the worse your ventricle is, the more likely it is that ECMO is going to be of benefit to you. I had the honor of being asked to write the editorial for this paper, and I summarized it this way, which is that, first of all, ECMO is a highly specialized intervention. It's not available in every hospital, and it probably shouldn't be. Second of all, these are vanishingly rare patients. How often do we see adult patients in septic shock with very advanced ventricular failure? It does not happen very often, which is a good thing. You know, we will often just see this maybe once or twice a year at most in busy ECMO centers. So it's not going to be something that we're going to be doing on a regular basis, but if we need to do it, we should, because these patients are generally young, often previously well, and their lives can be saved with an intervention which is second nature for many of us. So following on the Lancet study, we extended into a collaboration and did another SRMA, this time in adults, with individual participant data, which made it the methodology a bit more robust. So 14 studies, 468 patients, pooled survival was 36%. You may remember comparing that to children in a similar methodology, that was 65%. So the adults seem to have half the survival of the children. And again, I think that reflects degree of ventricular dysfunction. And again, interestingly enough, those with a worse left ventricular ejection fraction, as defined in this study by less than 20%, they did better. So those who had an LVEF of less than 20%, 62% of them survived, versus only 32% who had an EF of more than 20%. So where do we stand now? If a patient comes through the door tomorrow, when should I consider using ECMO for septic shock? Well, I think in children, and again, this is just my opinion, it's not backed up by particular science, but I think this is roughly where I would think we would be at if we are sitting around an inotrope dose of around 80 to 100. So that's 0.8 to 1 of epinephrine or norepinephrine. That other measures have been taken. We've obviously mechanical ventilation, we've had optimized fluid resuscitation, we've considered other non-catecholamine interventions, potentially calcium, hydrocortisone, vasopressin, etc. And despite that, the child is continuing to deteriorate. The lactates are going up, the acidosis is getting worse, the hypotension is progressing, multi-organ failure is evolving, and of course, the worst sign of all, once you start to see ventricular arrhythmias or cardiac arrest, then you know you've probably waited too long. So that was where I would intervene. In the adult situation, these are, I've just lifted them straight out of Nicolas Brachot's study. These are the inclusion criteria for his study. So an inotrope score, again, of around 75, or a lactate of more than 4, coupled to severe myocardial dysfunction, which in this study was defined as a cardiac index of less than 3, or an ejection fraction of less than 35%. So that's when I think we would consider it. When would we, or how would we do it? So this is a summary of the cannulation strategies we might consider. I've actually visited other hospitals where people have come up to me and say, "Hey, look at this. We're doing ECMO for septic shock, and it's VV, which must mean it must be better." Well, I think if you're able to get away with VV ECMO for septic shock, you're dealing with a different group of patients. Because again, I'm talking about those patients who need mechanical circulatory support, direct mechanical circulatory support, and VV doesn't provide that. So yes, if somebody is in septic shock and has advanced multi-organ failure, and the pulmonary manifestations are particularly severe, and they need VV ECMO, fantastic, go right ahead. But that's not the same group of patients that I've been talking about for the last 15, 20 minutes. So in small children, in infants, we would, of course, cannulate through the neck. The difficulty with that is that it may provide limited flow rates. I think you will struggle in many children to get more than 150 mils per kilogram per minute through straightforward neck cannulation. We can go through the femoral artery, and that would be the classic, would be the young adult with septic cardiomyopathy, as we saw in Nicolas' Lancet article. And then, of course, the problem, particularly as the ventricle recovers, if the lungs are impaired, then you risk differential hypoxemia. And of course, there's a risk of limb ischemia. We can overcome that risk by the use of VVA, so having 2 venous cannulas, one for access and one for return. That's technically very challenging in very small children, but it's very easy in adults and adolescents. And I think it's a very, very flexible, important modality to keep in mind. And then lastly, I have actually done central ECMO for septic shock in an adult before. It's not something I would rush to do again. They have a lot of nosocomial infections. They have a lot of bleeding complications. On the other hand, in children, if you're dealing with a very experienced cardiac surgical team who buy into the concept that this is an important way of supporting these children, and yes, they will come back at 3 o'clock in the morning when the silastic membrane fills with blood, and they will be with you the whole time, then yes, that is a very important modality, it's a very important cannulation strategy. We get very, very high flow rates. I mean, in an adolescent, for example, you can put a 56 French venous drainage cannula in the right atrium of these children. Show me how to get a 56 French venous cannula in peripherally. You just can't do it. And there is some data, not just the one I've discussed today, but other data, that this is associated with lower mortality in children. So I think central cannulation in children is a very important strategy. So this is my second last slide. Just in conclusion, I think nosocomial infections during ECMO have been inadequately studied, but nonetheless, they're a major determinant of outcome, particularly in adults on VA ECMO. That there is growing evidence that ECMO does have a role to play in vanishingly few patients with refractory septic shock with severe ventricular dysfunction. In general, we're needing ECMO very early on in infection before antibiotics have taken effect, usually within a few hours of admission to ICU. And that if you look at the published literature, in experienced centers, the majority of patients placed on ECMO for infection, irrespective of whether it's VV or VA, will survive. I think people shouldn't be dogmatic about cannulation strategy. It needs to be individualized both to the patient in front of you, as well as the experience of the team that you're working with and the experience of the center that you're working in, particularly for children who you're considering central cannulation on. So just to conclude, I'd like to highlight 10 principles, which again, some of these are almost self-evident, some of them perhaps being a bit more subtle. First of all, obviously the heater cooler will obliterate the febrile response. And we all know that, but it's important to think through the consequences. Can you imagine doing a round in your ICU where you're not allowed to know the temperature of any of the patients in it? I mean, obviously the temperature is called a vital sign for a good reason. And if you think about the difference, if you were going through a systems-based approach in your mind, whether or not the patient had a fever or not would have a huge impact on your day-to-day management. And of course, in the ECMO patient, we don't have that, ever. And I think that that needs to be acknowledged. We're kind of groping in the dark. Second of all, to try and overcome this, people have done surveillance cultures, so they kind of randomly send off specimens of blood, urine, and sputum. But this has been shown to be not cost effective. The yield is very, very low, and it's extremely expensive to do this in all of your ECMO patients. It's not recommended. Another question I get asked is, well, why don't I check CRP, procalcitonin, etc.? Let's use biomarkers. Well, people have studied this. There are at least 5 studies in both adults and children on the use of biomarkers to examine whether or not they have a usefulness in diagnosing infection. The short answer is that they don't. About half of the studies showed no relationship, and the other half showed that whilst sensitive, they were hopelessly non-specific. So if you measure a procalcitonin or a CRP in your ECMO patient, it doesn't matter what it is. It doesn't really help you. It should not be used alone to guide whether or not you start antibiotics in that patient. So biomarkers, I think, have a very limited role in ECMO patients. We've discussed the differences in the infection risk between VV and VA. With VA having the infection risk becomes a game changer, and it limits how far we can take it. Another important topic I haven't really talked about is the risk of rare infection because of contamination of the water inside the heater cooler. Now, there's a bunch of rare and environmental gram-negative organisms, such as Ralstonia pickettii, which many of you may not have heard of, which again, unless you talk to your microbiology lab and say, listen, we're looking for these organisms, then they may get overgrown by others, or they may not be cultured. And more importantly, then, of course, there is the non-tuberculous mycobacterial organisms. So things like Mycobacterium chimera, Mycobacterium abscessus, Fortuitum, colonia, these organisms will not grow in conventional culture. But they can grow rapidly under the right conditions. They may grow up in 1 to 2 weeks. So unless you ask for these cultures, unless you send patients' blood cultures in dedicated mycobacterial blood culture bottles, you will not diagnose these, and therefore you will not treat them properly. You put the patient on vancomycin and meropenem, it will do nothing for these organisms. So it's important to be aware of these. And indeed, I've looked after patients who the patient has behaved as if they've become septic on ECMO, and we've sent mycobacterial blood culture bottles, and lo and behold, we've grown Mycobacterium abscessus in blood, and therefore we know what we're dealing with and how to treat it. But if you don't look, then you're not going to know. We've discussed how longer ECMO runs are a risk factor for and a consequence of infection, which is an important issue, again, driving home the point that we need to get off ECMO as soon as it's safe to do so. Another important point, particularly when you're talking to infectious disease colleagues, they often think about duration. How long should we treat a documented infection for? Keeping in mind that you often will never be able to achieve source control until the patient is decannulated, particularly for bloodstream and cannula site infections. So having a kind of cookbook mentality, okay, so gram-negative sepsis we treat for 14 days and VAP we treat for 8 days, that doesn't apply to ECMO patients. We have no data to support that approach. And because of the absence of source control, you may need to run antibiotics much longer than you'd be otherwise happy to do. We also lack important PK/PD data, particularly in neonates, when that needs to be researched relatively urgently. And putting all this together, finally, therefore, the practical approach now is that we have a low threshold to start empiric antibiotics and a high threshold to stop them. So with that, I will thank you very much for your attention and hand back to Pete and Jordi.
Wow. Thank you very much, Graeme. That was awesome. I would like to invite all the listeners, all the attendees, to put in some questions in the question box. There are some questions coming in, and while they're coming in, I've got a few questions. I've got a question to start off with, Graeme, if you don't mind. You left me a little bit confused in a way that I've always considered a diminished left ventricular function in a child with sepsis as a possible indication for VA ECMO. Like you now mentioned, in adults as well. So if they have a clear diminished left ventricular function, that's something that you can bridge with a circulatory support. But now it seems that you say no, in children, even in distributive shock, with a you didn't mention the left ventricular function. Is that do you disregard that nowadays, and do you put them on ECMO with very high flows anyway, or is the diminished function a critical indication?
Well, I think it depends very much on your cannulation strategy and also what the indication for ECMO is. So, we think distributive shock, we think high cardiac output. The question in my mind is not high cardiac output. The question is it high enough? And in the Children's Hospital in Melbourne, which kind of pioneered this approach, we had a number of examples of adolescents presenting with distributive shock, but despite having high cardiac outputs, on a ton of inotropes with other appropriate therapy, fluid, et cetera, the lactate would go up and up and up, and then they would have a cardiac arrest. So you would resuscitate the child, you would have return of spontaneous circulation, and then the cycle would start over again. The cardiac output would be seemingly high even post-arrest, but the lactate would continue to go up and the child would arrest again. So where do you go from there? And in Melbourne, for reasons I don't think we need to dwell on now, but this approach about central cannulation came in. So if you're dealing with an adolescent who's having let's say the cardiac output is 7 liters a minute, but the lactate's 15 and you're having recurrent cardiac arrests, putting them on peripheral femoral ECMO, which is what those Asian studies I highlighted did, they were getting 1.5 to 2 liters a minute. So if you've got 7 liters coming out of your native heart and 1.5 to 2 liters going in the patient's groin, you're probably not really doing much. You're exposing the patient to all the hazards of ECMO without any of the benefits. Whereas if you crack the chest, stick a 56 French atrial cannula in and a 36 French aortic cannula, and you can get 10 to 12 liters a minute, now we can talk, because we're doing better than the patient can by themselves. If the patient has a cardiac arrest, never mind, we're still on VA ECMO. That doesn't mean we do nothing, but we can still support the patient. The lungs can be totally full of fluid, and again, central cannulation will cope with that. So I think it depends what your cannulation strategy is, and again, as I said earlier, I think this isn't something that I would recommend in every hospital on the planet. It's in very experienced pediatric cardiac surgical teams who know how to do central ECMO well, and there is a difference in surgical technique between in how you perform central cannulation and also how engaged the surgeons are. I've had surgeons, not kidding, I've had American surgeons call me during my ward rounds in Singapore just wanting to know that this is acceptable practice in parts of the world, to do a sternotomy on a virgin chest for a child with refractory septic shock, and to know that this isn't some outlandish concept. So I think, you know, if you're prepared to do a sternotomy for a child to fix their ASD, and we have now some evidence that central cannulation is associated with better outcomes, then is it outlandish to crack the chest and put them on central ECMO? No, I don't think it is. I think under certain circumstances, it's a very good idea and something that people should think about.
Yeah, so even if their left ventricular function is still okay, but it's just not okay enough to provide that very high required cardiac output.
Yeah.
That makes sense. Jordi, can I invite you? Do you have a question?
I'm hearing you. This is a very interesting conversation. We are talking about high flows, but what is high? I mean, you have flow, ECMO flow. You have a value there, obviously, but which is important is the patient's needs. So maybe with 5 you're okay, or maybe the patient needs 7. So the cannulation strategy also for adults is very important, especially the drainage cannula, so you can achieve high flows. So I think this is a good summary in regards to these issues. So cannulation strategy, again, it's of paramount importance in regards of ECMO success, also in these patients. So I will take, if you agree, Pete and Graeme, some very interesting questions from the virtual floor. So we have, again, for the listeners, we have 2 questions here, which is the infectious process and complications in ECMO patients and the use of ECMO in septic patients, okay? So I will try to start with the first part, if you agree, which is René Gomez asked us a very difficult question, which is, summary, which are the signs of infection? What should we trust in to do something, which is obviously starting antibiotics and so. Which sign do you recommend to be the most important or to fix or mind in this value?
So if I can just clarify, the question is what's the best early warning sign that the patient is developing nosocomial sepsis? Is that the question?
Yeah, while on ECMO,
Yes.
I think. Yeah.
Yeah. So obviously, you know, we've talked fever is useless, biomarkers are dodgy. So relying on them is going to mislead a lot of people. Fundamentally, I think the most important thing that I look at for a particularly severe infection is an increase in metabolic demand. So that's going to manifest on VV ECMO as a drop in systemic oxygen saturation. So minding your own business, and then the patient starts to slowly desaturate. And that's usually because the cardiac output, particularly in older patients, the cardiac output is going up, the ECMO flow stays the same. So therefore, the proportion of blood going through the ECMO circuit in relation to native total cardiac output is going down, and therefore the saturations go with them. So I think that would be the first thing where I would think that we're missing something here. The saturations are going down, and it's not the lungs. And obviously, we need to conduct a thorough clinical examination. We'll get a chest X-ray, look for worsening infiltrates, pus coming out of the cannula sites, send off septic workup, send off cultures, but of course, they're going to take some time to get back. On veno-arterial ECMO, we may see other things. Particularly those of you who look after children with cyanotic congenital heart disease will know the AV oxygen difference is something we keep a very close eye on. So the difference between arterial saturation and venous saturation, we want that gap to be less than 30%. And if that gap starts to widen, then that may be an alarming sign that things are getting worse. And in adult patients who may start to see the lactate going up. Now, in many respects, these are blunt tools. Waiting until somebody's lactate is climbing on VA ECMO before thinking, I wonder if they're septic, you're probably quite late in the day. Nonetheless, I think it just highlights the difficulty of getting it right in these patients. So again, it's a combination of things. It's identifying patterns, but I think looking for those early signs of an increase in metabolic demand is where I would put my money on.
Yeah, and I also think I sometimes see that they develop a new hemodynamic instability that could be a sign of a developing infection. So they had good cardiac output, your ECMO run is smooth, but then they start having blood pressure issues or start to dilate. So in the clinical exam, you see that something's going on, and that might sometimes be the start of an infection. They can be obscure signs, and I think you have to take every small sign, seriously.
Absolutely. It's also what we find here is that patient that is getting an infection, they start clotting the system, they start bleeding, and they have very variable in regard hemostasis situation. This is another pretty interesting, uncommon sign of an ECMO patient getting an infection. So, Pete, should we get another question?
Yeah.
Okay.
Graeme, do certain infections in ECMO patients mean an absolute no-go for you? Like for me, like you mentioned briefly, the Bordetella, pertussis children, the very young ones, if they come in a state that they require ECMO, we know that they do very, very poorly. Are there any other infections in children and in adults that you would just use as a very hard contraindication for ECMO?
Yeah, I mean, if we ignore emerging infectious diseases for a second, the short answer would be no. I think, as with so many things, this is not dichotomous. If we talk to Jordi, for example, about what's your upper age limit in adults with COVID? Is it 60? Is it 65? Is it 70? Is it 69? Is it 63? Is it 55? I mean, why we shouldn't be arbitrary about these things. In general, it's good to have a range. And if I'm looking after a neonate with pertussis or disseminated HSV, in and of itself, yes, that rings alarm bells. It says this is going to be a high-risk ECMO run with a higher chance than normal that it's not going to work. And I'm going to tell the parents that, I'm going to tell the team, but I'm still going to go ahead. However, if that's added to a bunch of other things, maybe the child's got trisomy 13, for example, then that's going to push me in the direction of saying no. Just as an adult with COVID, who is 65 and on dialysis, is probably going to push me more towards saying no than yes. So it's going to be a factor in the decision making, but it's not going to be a game changer, if that makes sense.
Exactly. There's nothing really black and white, is there? There's a lot of grays and a lot of things to consider. Whereas, like you mentioned before, a few years ago, the stem cell transplantation patients and the neutropenic patients, they were a very hard no, but that's changing over the years. We've noticed that people are achieving good results if they get the selection right, and that's so difficult, but so important to do. Yeah, there's a question about the neutropenic patients. Somebody asked, let me see what the actual, what would be the duration post stem cell transplantation to render ECMO less likely to be successful? So is there a duration of time that you would say, I would not consider it, or at least say that I'm very worried that it might work?
Yeah, well, so you may know that the first, this is to my knowledge, I could be mistaken, but the first patient who was ever treated successfully after an allogeneic stem cell transplant was a 6-year-old boy with Hurler syndrome who'd had an allogeneic bone marrow as an infant. So he was several years past, and he now presented with a new problem that had nothing to do with bone marrow transplantation. I think he had pulmonary hemorrhage, and he was put on ECMO and he survived. So I think the further you are away from the transplant, the better you do. And we've seen data. Peter Shalangowski from Vienna and others have shown nicely that the closer you are to the transplant, the worse the outcome will be. So some people say, oh, it should be 6 months or 270 days. Others look at whether or not the patient's engrafted. But basically, the closer to the transplant, the worse they will do. And again, I think we struggle to be arbitrary about this. But again, it will, if it's somebody, for example, who's got undiagnosed respiratory failure 2 months after an allogeneic bone marrow transplant, and particularly if they have high-risk features, in consultation with the oncologist, then the answer is more likely to be no than yes, because what we don't want to do is to take a costly, high-resource intervention which makes no difference to the ultimate outcome, because then nobody benefits. So
exactly.
these are difficult questions, but yeah.
I think the latest guidelines for pediatrics says that if there's no engraftment, the chances of surviving ECMO are so very slim. You should really consider not offering ECMO. So engraftment is an important point. And then there's a long time of gray area behind that with all the other risk factors involved. That makes this very difficult decision every time. Yeah.
Yeah, so just to highlight, one of your colleagues in EuroELSO, Matteo Leonardo from Bambino Gesù in Rome, did a lovely paper recently in Lancet Child and Adolescent Medicine, which went through all these issues in detail, at least in pediatrics. And again, difficult area, and the adult literature is equally gray on this. But I think if there's one take-home message, this is no longer an absolute contraindication to ECMO.
Exactly.
That doesn't make it easy, though.
There's a few questions about fungal infections. I see people say, what if you suspect a fungal infection, or even if you diagnose a fungal infection in a patient on ECMO, what do you do?
Well, I guess first of all, it depends what the fungus is. So there are certain fungi which are hard to treat at the best of times, even in immunocompetent patients. So Scedosporium, for example, if you get that in your bloodstream, you're dead. So ECMO is not going to change that. More often than not, of course, it's something like Candida, which is amenable to treatment. And if you look through the history of fungal sepsis and ECMO, historically it was regarded as having a mortality approaching 100%. But there have been successful treatment. Of course, fungal sepsis, I think, needs two things. It's a bit like dealing with sepsis in the immunocompromised patient. First of all, you need appropriate early antifungal therapy. And second of all, hopefully you have a functioning immune system. The problem arises is when you have fungemia in the ECMO patient, the lack of source control or the lack of ability to achieve source control may be a deal breaker. Because if you can't change the ECMO cannulas, you can't change the lines easily, or they develop deep-seated fungal infection. For example, if they have intra-abdominal sepsis, then the chance of them pulling through is very, very low. But I think ECMO is usually complicated by fungal infection rather than being used for fungal infection. I think if somebody has catastrophic intra-abdominal sepsis and fungemia, for example, in general, these patients don't lend themselves nicely to being supported on ECMO because the prognosis is too bad. The more common scenario is the patient who's already on ECMO and develops nosocomial fungemia, in which case, hopefully you make very aggressive attempts to achieve source control and boost their immune system and try and get them off as fast as you can.
Jordi, do you change ECMO circuits when you have, or parts of the circuit? There's a question about changing the oxygenator. Does that have any impact on reducing the sepsis in your opinion?
Well, nice photographs in the literature. See these white spots, no?
Yeah.
If I'm not wrong. Well, I do not do it, but yes, it is very important. Fungal infection, if you have candidemia or aspergillus in the lungs, the question is if it can be a sign of an immunodepressed patient, which this is the difficulties. You find difficulties with these immunosuppressed patients, not the pathogenic attitude of the fungus also, but not only this. So interpret the fungal infection as, okay, the immune system of my patient is not working properly. So you have to address in parallel these 2 points. This is one point. Another point is, yes, it depends on the fungus and the site of the fungus. It could be a colonization of the airways, but it's in the blood. Obviously, you probably have the fungus in the catheters, in the cannula. So you change the oxygenator and you have the fungus in the cannula. So another point is you have to treat it properly and treat it energically. Here, empiric treatment, we associate antifungal therapy, empiric treatment. We take cultures, and we go with broad spectrum antibiotics, antibacterial drugs, and also antifungal. And then we wait for them and we titrate the treatment. So it's not a question of changing the system. It's difficult. You have to change everything, to me, if you choose doing this. But the most important is to empirically treat fungal infection, and then another point is PK/PD of antibiotics. This is very important. There's a question about associated two antifungals that make sense. Again, we don't have enough literature, we don't have enough data, but the most important is if you put one, you put it properly. So TTM is very interesting. We are measuring now in echinocandians here. We find they work, the PK/PD of them, they work properly. But it depends also, if you change the system, the PK/PD changes. So again, the devil is in details. And unfortunately, we don't have enough data. So in summary, your question is, if I change oxygenator, the brief answer is no, I don't do this.
No.
There's another question. Do we have time, Pete?
Yeah, let's do a couple of more minutes. I think there's a few questions, and then we will round it up.
Okay, there's another one about cytosorb, which is from Timur Lesbekov. This is a very nice question. What do you think, Graeme, about the use of cytosorb in septic patients?
So cytosorb, it obviously comes with additional cost, and if I'm going to spend, at least it depends on the medical system that you're working in. If I'm working in Germany or Australia or somewhere like that where medical care is free and paid for by the government, then I may be more willing to try these therapies. In Singapore, the patient has to pay for them, and yes, the government will help with the size of the bill. But if I'm going to use a more expensive treatment, I want evidence that it actually does something. And please correct me if I'm wrong, but to my knowledge, there's no evidence that cytosorb decreases mortality in septic shock. So it's not something that I would rush to do.
Yeah,
I have no experience with cytosorb. So.
Well, it's always theoretically, yeah, you retrieve inflammatory molecules, but maybe you are retrieving also anti-inflammatory molecules. So it's, but well, it's a priori it makes sense. But yes, I agree. There's no solid evidence of its value in this setting. Pete, another question from the floor.
Yeah, I had a question coming in over about pediatric neck cannulation. So you have a child with, on VA ECMO for, I don't know, doesn't really matter. So on VA ECMO and develops a sepsis and requires more flow. Would you then consider first adding a second venous cannula to increase flows, or would you consider opening the chest and going for central?
Yeah, so it depends on the age of the child. If you are looking after a child that's small enough where neck cannulation will be your standard approach, where are you going to put your second venous cannula? You can either put it in the left internal jugular vein, in which case you now have 3 cannulas in the neck, and I concern myself about potential neurological injury by doing that. Or you couldn't put it in the legs. Now, in most children who are cannulated through the neck, they don't walk, and that's why you've gone for the neck, is because the femoral vessels are relatively hypoplastic. So you're not going to be able to get a decent sized venous cannula in there. In a neonate, for example, you would probably manage to maybe get a 6 French cannula in at best. And even then, there may be problems if the child flexes the leg, or it may be very positional. So it's a lot of effort and potential risk to go through for a little bit of extra flow. On the other hand, the decision to crack the chest is not an easy one either, particularly if this looks like a long run. If you're opening the chest for what you know is going to be a very quick, 3 to 4 day ECMO run, fantastic. But if you're putting a child on ECMO, central ECMO, for something that may take 2 or 3 weeks, then that's going to become very problematic very quickly. So unfortunately, I can't give a kind of easy, snappy answer to this. No. It's a difficult question, and I think it has to be individualized to circumstances. But I think the question itself highlights the limitations, in particularly neonatal ECMO. We don't have that many choices where we can, we can't put it in the axillary artery. We have huge problems trying to cannulate the femoral vessels. It's the neck or the open chest, and both of those have their own problems. So it's a question of which problem that you're prepared to expose the patient to.
Yeah, makes sense. There's one very specific, one last question about a patient with necrotizing enterocolitis, which is something that we see in the infants due to sort of ischemic bowel. And those children sometimes need an operation, and sometimes they have a part of their bowel resected. And somebody asked, Mariela Vargas asks, if you would consider an open abdomen after an operation for a necrotizing enterocolitis. Would that be a contraindication for ECMO? So the child develops sepsis because of the necrotizing enterocolitis, needs hemodynamic support, but has an open abdomen. I'm sure that would give some bleeding issues, and in open chests we don't see as a contraindication. I have no experience with open abdomens. Have you, Graeme?
Yes, I do. They're obviously in a high risk group, and as you correctly highlighted, bleeding is a problem, nursing care is a problem, and then down the track, nutrition and the risk of, again, fungal sepsis becomes a huge problem. So it's not something that I would likely trip into. On the other hand, if you're committing yourself to an ECMO run, then I think you're also committing yourself to having no holds barred, which means coming up with excuses why, we'll do ECMO, but we won't do this, or we're not going to do that. I think that's not acceptable. If you're trying to treat the patient seriously, you're already invoking the kind of last ditch form of cardiopulmonary life support, then you owe it to the patient to try everything else. So open abdomen or not, open chest or not, do your best. And if things get out of hand and the patient passes beyond support, okay, well, at least you tried. But yes, it can be done, but they're in a very high risk group.
But you need buy-in from the entire team, like you mentioned before. You need the cardiac surgeons if you're doing open chest ECMO, but you need everybody involved to be prepared to do everything while the child is on, or the patient, the adult is on ECMO.
And obviously you need to try and get them off ECMO as fast as humanly possible and get the abdomen closed, which is easier said than done.
Well, thank you, Graeme. I've learned a lot, pediatric wise, but also adult wise. It's always very interesting, and I'm really happy to see both patient groups addressed, because there is certainly so many things that we can learn from each other, and I really enjoyed this. Jordi, do you have any closing remarks? Any last?
Of course. It has been a fantastic webinar. We learned a lot from Professor MacLaren, such a big expert. Fortunately, we don't have strong data. We don't have strong clinical trials about both the infectious complications in a patient on ECMO and also the use of ECMO in septic shock, maybe in pediatrics. Not a lot in adults, only cases and observational studies. Again, it has a very big impact on patients. You have to do prevention of infectious complications, and you have normally problems to identify infection complications, unfortunately, in patients. Think about increase of metabolic demand in the patient. Maybe you have an infectious process there. Maybe the patient is bleeding, but they don't change. You have to change a lot the dose of heparin you have to give to your patient. The system is clotting. Think about maybe the patient is getting infection. You can get infection from bacterial side and also fungal side, and it has a very big impact. It depends on babies and adults, the proportion. It seems that in adult patients, you have more infection processes per ECMO days. And finally, ECMO, yes, in pediatrics, it has a real role if the patient is in septic shock. In adults, especially if they have a cardiogenic pattern, or shock in the context of infection. I think this has been wonderful, and yes, so I enjoyed so much.
All right. Thank you very much, Graeme. Then we'd like to round it off. I want to remind people that this webinar is going to be available on the EuroELSO website within a few days. And also that we're going to have the EuroELSO meeting in May, so it's very soon. And there is now also a virtual option for you to join remotely if not available to come. And then in September, I think the ELSO meeting is in Boston in the United States. So we have ongoing webinars as well, conferences. There's many things that we can learn from each other. So I hope to all see you either online or at one of these meetings in the future. Thank you very much for attending. Thank you very much, Graeme and Jordi, for doing this together. Have a great day, everybody, and we'll see you soon, hopefully.
See you in London.